you know, the challenge, as you go to subsequent line therapy in colorectal cancer patients, third line, fourth line, you get into a balancing act of what toxicity is worth the freight, as well as are there experimental or research things that you might prefer and offer patients. In fact, at our center, we offer patients research opportunities, perhaps in lieu of either regorafenib or TAS-102. Sequencing them is hard to do. Very few of our patients ever get both of them. And which one goes first is more the bias of the physician, treating physician. I tend to favor regorafenib before TAS because I've seen a lot of neutropenia and cytopenias with TAS, although that may be a biomarker for response. And I'd be the first to admit, I'm not sure we know how best to use those drugs. It's a tough one because they're sort of in a parallel universe and it's more experiential than it is data-driven. So very tough call right now, and it's a balancing act of toxicities versus sort of expectations. Neither of them is a great drug in terms of making a big difference, and so again, our bias has typically been to put patients on studies rather than using those drugs. And again, almost never do we get to sequence them just because patients they just run out of energy with either one, at least in our experience.